Hello everyone. Now I'll discuss question of respiratory system. So we are getting a 52-year-old man come with the increased dyspnea on exertion, dry cough and wheezing over the last 2 months. So 52 year, 2 months. Well, he never had this symptom before and they are worse at night now for the last 2 months at night. Well, he's a case of hypertension, coronary artery disease, aspirin, amlodipine, lisinopril, simvastatin and metoprolol. He smoked for 30 years but stopped 10 years ago. Well, he's 52 years, okay. Long history. No family history of asthma, BP normal, respiratory rate is even 16 per minute. Oxygen saturation 95% on room temperature. BMI very high, obese man, and JVP just 3 centimeters above the sternal angle. Heart has a regular rate and faint S4, no murmur. Well, he's a hypertensive also. The lung shows good movement with diffuse wheezing and no crackles. Chest X-ray is unremarkable. Pulmonary function test was pre-bronchodilator and post-bronchodilator. FVC 85% of the predicted. FEV1 67 definitely low. Diffuse ratio is reduced. In fact, when the ratio is less than 0.7, that indicate obstructive airway disease. So that also confirmed. And diffusion capacity is normal in this case. Post bronchodilator, FVC 88%, FEV1 82%. From 67 it has come to 82. If you see improvement is 82 minus 67, so almost 15% improvement is there. What conclusion we are getting? He has a obstructive airway disease, but it is reversible. More than 12% is reversible, and that's a feature of bronchial asthma. Okay, by now we have really concluded that we are dealing with asthma. Okay. Well, we already made the diagnosis of asthma. But before I proceed further, again we revisit the question. Look into his medication. See it again. Aspirin, amlodipine, lisinopril, simvastatin, metoprolol he is taking. Now, can any one of these drugs, and remember this he is taking for a long time, okay? Now, can any one of these problem can worsen his asthma problem? Stop the video, write down the answer. Which drug should not be given to this patient if the patient comes to you? Well, the answer is metoprolol. Metoprolol is a beta blocker. Although it is a cardio-selective beta blocker, but still some element of bronchospasm cannot be ruled out. So if this question comes to you, then the best or the most appropriate answer is metoprolol. One thing you got to learn the exam technique. In the exam when you go, examiners never say choose the right answer. He says choose the most appropriate answer out of this metoprolol. And now I'm sure there must be in your mind, what about aspirin also? Aspirin also a contributory factor, especially to adult onset, but the patient must be, that means there are two drugs which are dangerous for this patient. It's just the information. Anyway, we continue our discussion about this patient, but definitely we got some good input from this other thing also. So now asthma, patient present with the classical triad of asthma. Dyspnea, wheeze and cough are the classical triad of asthma. Cough is a dry cough. Is a dry cough. And is the earliest feature of asthma. Dyspnea is the most common presenting symptom. Wheeze is the most characteristic feature. And the best thing is a positive bronchodilator response more than 12% increase in FEV1, which already I've calculated 82 minus 67, 15%. Point to be noted, we are getting a 52-year man coming to you with a breathing difficulty for the first time for the last 2 months. and we are getting a reversible type of airway obstruction. As I told you, usually it is asthma is the problem of young individual, but we are getting a 52-year. So adult onset asthma tend to be more severe and less likely to go into remission. Point to be noted. Now, patient has a history of smoking also. Okay, and why can't we COPD? Yes, strong possibility. The patient smoked for 30 years, but although he stopped for 10 years ago, but COPD cannot be ruled out. So in such cases, we always like to go for pulmonary function tests. That we did in this case also. And both disease show airway obstruction. I told you the criteria of obstruction airway is FEV1, FVC ratio less than 0.7. This was also question. Okay, and FEV1 is highly reduced. FVC is reduced. So that's why the ratio is very low. It is one of the diagnostic feature is less than 0.7. So, but COPD may show partial reversibility in early disease, but complete reversibility is unusual, and there is complete reversibility in case of asthma. So that means when we are talking about it, a reversible criteria we differentiate regarding which is asthma or COPD. So it is reversible in asthma and no reversibility or partial reversibility. So we got the PFT done. We see this ratio was less than 0.5 and FEV1 improved. We are dealing with reversible airway obstruction. Now, second thing which is usually not discussed and not known to more than 80% students are not aware point. Even we also use diffusion criteria also, DLCO, in asthma and COPD. Okay, it may be a rather sometimes a very important differentiating feature. In asthma is usually normal or increase in severe asthma. Point to be noted. It is never increase in patient of COPD, never. Okay, though it may be normal in early chronic bronchitis, it may be normal, but definitely it's not increase. So it is normal or reduce. It is normal or increase. And this decrease is very common in patient having emphysema. In emphysema, it is highly reduced. Rather, it is there was a question for you. What happened in DLCO in emphysema? It is definitely reduced. So, additional thing that regarding the patient having obstructive airway disease with increased DLCO, think about asthma, reduce is COPD, especially emphysema. Okay. Now let's look into other option is bronchiectasis. But before I discuss, in bronchiectasis, cough is very important. Now, what are the characteristics of cough in a case of bronchiectasis? Stop the video, write down the answer. Well, the answer is these patients have dyspnea, cough, and obstructive airway disease on spirometry. Cough is maximum in the morning. Copious amount of sputum in a particular posture. Okay. So this is the classical particular posture. Large amount of sputum is there. And the chest X-ray in bronchiectasis is usually abnormal and they show a tram track or signet ring appearance. Let me show you just beautiful signet rings. Look into this. Lovely rings. Cannot afford to forget this. Then tram tract appearance. Look into this. Lovely tram tract appearances there. Okay. Look into this. Lovely tram tract appearances there. Let's look into other option. Option D and E, they are incorrect. Diastolic heart failure and GERD, gastroesophageal reflux disease. Nocturnal cough and wheezing are common in GERD and is uncommon in heart failure. Although paroxysmal nocturnal dyspnea, PND, can occur in LVF, but nocturnal cough is usually not seen in heart failure. especially in diastolic heart failure, to be more precise. Reversible airway obstruction is not seen in either of these conditions. This is a feature only in asthma. In fact, this one line is the moon among the star. If you are getting any question where patient has dyspnea with reversible airway obstruction, that means 99% you are dealing with bronchial asthma. Fourth heart sound may be due to long-standing hypertension. Now, again, I have a question for you. Stop the video, write down the answer. Fourth heart sound is produced by in which phase of cardiac cycle? Stop the video. Well, it is produced in the late diastole. It is due to atrial contraction. Atrial contraction against the stiff ventricle wall. Maybe due to hypertension, maybe coronary artery disease, etc. So S4 is produced in the late diastole, and that's why, due to atrial contraction, that's why this is also known as atrial sound or atrial kick also. Atrial sound or atrial kick. So a golden line to remember: asthma diagnosed by maybe childhood or early adulthood. In some cases, it may be there in the first time in the late adult, like in our case. Pulmonary function test and reversible airway obstruction more than 12%, with normal or increased diffusion capacity for carbon monoxide. In fact, if I have to tell you even simpler than this, if you are getting reversible airway obstruction, this is 99.9% you are dealing with bronchial asthma. Okay, because none of the other important disease like COPD or bronchiectasis, they are not reversible. Thank you very much.